Just a few words of introduction. This presentation describes a phase 3 randomized trial of a so-called checkpoint protein inhibitor. That is, Nivolumab is a human antibody which abrogates or blocks the activity of a substance called PD-1, or programmed death 1, which is present on immunologic cells or T cells in the human body. And in a state of chronic antigenic stimulation, such as the cancer state, or for that matter, certain chronic viral infections, it is highly upregulated and tends to suppress the immune system. In fact, the immunologists have a term for it. They call it immune exhaustion. So when this substance is highly expressed on the immune cell, the immune system no longer functions adequately, and it certainly does not function to eliminate tumors. The idea is that if you had an antibody that could block the interaction between this substance called PD-1 and the ligand, or the substance that binds to it, which is called PD-L1, which interestingly is highly expressed on tumors. In the tumor microenvironment, the tumor tends to suppress the function of the immune cells by binding the PD-L1 on the tumor to the PD-1 on the immune cell. So if you could block the interaction with an antibody, as you might expect, you might allow the immune system to proceed in an unfettered manner and allow tumor regression to proceed. And in animal models, that works very well. In phase 1 studies that were published in 2012, 2013, 2014, indeed there was evidence that this antibody against PD-1, called Nivolumab, could induce significant levels of tumor responses in patients with melanoma, kidney cancer, non-small cell lung cancer, and other malignancies. So the current trial is now a more definitive phase 3 comparison where patients with metastatic melanoma that had failed prior standard therapy would receive, in a 2-to-1 randomization, either Nivolumab at 3 milligrams per kilogram every other week, or what would be regarded as the standard treatment in both the US and in the EU and Australia and Canada of chemotherapy. And it says here investigator choice chemotherapy, and the reason why it says investigator choice is that in Europe, dacarbazine as a single agent is often used for patients in second or third line chemotherapy. In the US, we use carboplatin and Taxol. So that's why it's investigator choice. And the co-primary endpoints of this trial were both response rate, which was to be assessed relatively early on in the trial. So the trial was designed to accrue 405 patients in an imbalanced randomization, 2-to-1, Nivolumab versus chemotherapy, early on when a certain number of patients would have gotten to the 24th week, at which point you have an assessment of response. We were going to determine the co-primary endpoint of response. As you can imagine, later on in the trial, when enough events of death had taken place, you would be able to assess whether there was a difference in the overall survival. And the trial was stratified to find out if patients who had the expression of this ligand, PD-L1, on the tumor, or those who had the so-called BRAF V600 mutation, or those who had previously responded to the ipilimumab drug and then failed, whether there was any difference in outcome. That's why that stratification was done. And in this trial, the adverse events are shown here, and I think it's pretty clear as you look at the data outlined in red. When I think of the toxicities of a clinical trial like this, I think of what was the rate of grade 3-4 adverse events, meaning the serious or significant adverse events that really impacted on patients. And it's pretty obvious that if you look at the data outlined in red, that there's a much higher rate of adverse events in the arm that got the investigator choice chemotherapy, and that's the ICC arm that you see on the right, versus the group that got the Nivolumab. So 31% significant rate of adverse events, grade 3s and 4s for chemotherapy, only 9% for Nivolumab. And if you look at the bottom row, you'll see that the rate of those who discontinued from toxicity was also quite imbalanced. It obviously favored the Nivolumab arm. 8% of those who got the chemotherapy had to discontinue versus only 2% who got the Nivolumab. So in terms of side effects and toxicity, a clear edge or benefit to the group that got Nivolumab. In looking at the important endpoint of response and duration of response, because remember, just getting a response in oncology is not the name of the game. It's whether you have a response of long duration. So if you look at what we call the swim plot, which is the horizontal plot of the response, the vast majority of responders stay in remission who got nivolumab, and the response rate for nivolumab for all those who were evaluated at week 24 is 32% versus only 11% for chemotherapy, a clear advantage for the nivolumab immunotherapy arm. The vast majority of the patients who responded to nivolumab are still in remission. So if there were 38 responses to nivolumab, 36 are still in remission. And if you look at this so-called swim plot, the little yellow arrowheads indicate a patient who continues in remission. As you can see, the vast majority of patients continue in remission. And if you look at the duration of response in the patients who got chemotherapy, it's only about 3.5 months. Whereas if you look at the duration of response for those who got nivolumab, the immunotherapy, it has not been reached. So that median duration of response is not reached. And if you look from across the room, it's pretty obvious that it's going to be a long time because 95% of the patients are still in remission. So obviously a highly favorable outcome for the nivolumab group compared to the chemotherapy group. And finally, if you look at the speed with which people responded, it obviously favors the group that got the nivolumab. It was only 2.1 months median time to achieve a response versus 3.5 months for the chemotherapy. And at the bottom, you can see there were 5 chemotherapy responders. Some of them are still ongoing, but obviously a very large number of responses, 38 out of the total of 120 patients who got nivolumab, so that's 32%, who had a response by very rigorous central criteria where there was objective outside radiologic review by the criteria of RECIST 1.1, which is the most rigorous response criteria that we use in oncology. So the conclusions of this randomized trial, whose data will be presented at an initial analysis of response only. We will not be presenting the progression-free survival or survival data until enough events have occurred. In patients with advanced melanoma who progressed after receiving ipilimumab therapy, and if you were BRAF mutated, you had to have also failed after receiving a BRAF inhibitor. There was a response rate of 32% with the immunotherapy arm of nivolumab compared to 11% with patients receiving investigator choice chemotherapy. It was all assessed by a very rigorous RECIST 1.1 centralized radiologic review. The majority of responses in the patients who got nivolumab, 95% of them are still ongoing. The median duration of response has not been reached and will be very long. Responses were observed regardless of whether you had PD-L1 staining of the tumor pre-treatment, regardless of whether you were BRAF mutated V600 or not, and regardless of whether you had previously responded to ipilimumab or just had gone right through ipilimumab and failed. The grade 3-4 treatment-related adverse events were 31% in the investigator choice chemotherapy patients versus only 9% in the nivolumab patients. And the majority of the nivolumab treatment-related side effects were of low grade. They were manageable using the standard treatment algorithms that we all use in oncology today. Overall, nivolumab was superior to chemotherapy in terms of toxicity and response rate for patients that failed prior ipilimumab, and in my view, should replace chemotherapy in routine practice for second-line or even third-line melanoma patients. Thank you.